Wake up, mouth feels like sandpaper. Mouth feels like sandpaper, lips slightly stuck together. Lips slightly stuck together. The first swallow is uncomfortable. The first swallow is uncomfortable. You drink some water. It passes. You get on with your morning. It passes. You get on with your morning. Most people file this away as nothing. You get on with your morning. Most people file this away as nothing. Slept with their mouth open. Room was dry. Drank too little water yesterday. Most people file this away as nothing. Slept with their mouth open. Room was dry. Drank too little water yesterday. Reasonable explanations and sometimes accurate ones, but sometimes it's something else. And the reason almost nobody knows what that something else might be is that dry mouth, the medical term is xerostomia, from the Greek for dry in mouth, but sometimes it's something else. And the reason almost nobody knows what that something else might be is that dry mouth is one of those symptoms that sits in an awkward clinical gap. It's too minor for most people to mention to their doctor. It's too common to trigger immediate concern, and it occurs at a time of day, while you're asleep, discovered only on waking, when most people aren't paying close attention to what their body is doing or trying to tell them. That gap is worth closing. Because morning dry mouth, when it is not explained by obvious factors like an exceptionally dry bedroom environment or a night of heavy alcohol consumption, can be an early peripheral signal of several conditions that matter significantly in adults over 60, conditions that are far more responsive to intervention when caught in this preliminary symptom level phase than when they progress to the point of clinical obviousness. Conditions that are far more responsive to intervention when caught in this preliminary symptom level phase than when they progress to the point of clinical obviousness. Today I want to walk through what saliva is actually doing in your body, what disrupts its production, and what the specific pattern of waking dry mouth may be telling you depending on what else is happening. Saliva first, because most people do not think of it as medically significant, and it absolutely is. The average adult produces between 1 and 2 liters of saliva per day. That production is not continuous at a fixed rate. It follows a circadian pattern. Salivary flow is highest during the day, particularly around mealtimes, and drops significantly during sleep. This nighttime reduction is normal and is part of why most people's mouths feel somewhat drier in the morning than in the afternoon. But normal nighttime reduction is not the same as true xerostomia. The distinction is this. In normal sleep-associated salivary reduction, the mouth feels somewhat dry on waking but recovers rapidly and completely within a few minutes of being awake. The discomfort is mild and transient. In true xerostomia, the dryness is more severe, may involve difficulty speaking or swallowing the first words and swallows of the morning, may be accompanied by a sticky or tacky feeling in the mouth, and may persist well into the morning even after drinking water. Saliva performs functions that most people never think about until they're absent. It maintains the oral pH in a range that protects tooth enamel from the acid-producing bacteria that cause decay. It contains enzymes, primarily amylase, that begin starch digestion before food reaches the stomach. It contains antibacterial compounds, lysozyme, lactoferrin, immunoglobulin A, that suppress the overgrowth of pathogenic bacteria and fungi in the oral cavity. It lubricates the mucous membranes that line the mouth and throat, protecting them from the mechanical abrasion of speaking, chewing, and swallowing. And it maintains the moisture of the oral tissues in a way that supports the integrity of the mucosal barrier, the thin tissue layer that separates the interior of the mouth from the bloodstream. When saliva is chronically insufficient, when morning dryness is not a transient artifact of normal sleep physiology, but a persistent symptom of inadequate salivary gland function, the consequences accumulate. Difficulty swallowing, which in older adults is a contributing factor to aspiration risk. The relationship between oral health and systemic disease, particularly cardiovascular disease and diabetes, is now sufficiently documented that it appears in cardiology and endocrinology guidelines. So the symptom is not trivial, even when it seems like it. Now to what it might be warning you about. The first and most important possibility is sleep apnea. Sleep apnea, specifically obstructive sleep apnea, causes repeated cessations of breathing. Estimates suggest that somewhere between 30 and 40% of older adults have at least moderate sleep apnea. The majority are undiagnosed. Morning dry mouth is one of the most consistent and most specific self-reported symptoms of sleep apnea that does not require external observation. Nasal breathing warms, humidifies, and filters air before it reaches the lower airway. Oral breathing bypasses all 3 of those functions. Additionally, sleep apnea is associated with increased nasal resistance and nasal congestion, both of which independently force mouth breathing. Daytime fatigue that does not resolve with adequate sleep, or waking briefly with a sensation of gasping or choking. Through mechanisms involving intermittent hypoxia, sympathetic nervous system activation, and inflammatory pathway upregulation that occur with each apneic event throughout the night. And it is eminently treatable. Continuous positive airway pressure therapy is one of the most effective treatments in all of sleep medicine. The second possibility is less immediately alarming, but clinically significant in a different way. Diabetes and prediabetes. As glucose concentration in the bloodstream rises, the osmotic gradient draws water out of glandular tissue, reducing the volume of fluid available for saliva production. Additionally, chronic hyperglycemia damages the small blood vessels and nerves that supply the salivary glands, the same microvascular and neuropathic damage that causes diabetic retinopathy in the eyes and diabetic nephropathy in the kidneys. This microvascular damage progressively impairs the gland's capacity to produce saliva, creating a relationship between glycemic control and salivary function that persists even when acute glucose levels are managed. And the researchers noted that the salivary changes were detectable in people with prediabetes as well as established diabetes. The combination points toward glucose dysregulation that warrants a fasting blood glucose and HbA1c measurement. These are inexpensive routine blood tests. The average American over 65 takes between 4 and 5 prescription medications, and because dry mouth is one of the most common and most underreported side effects. Diuretics, which reduce total body fluid volume, including salivary gland secretion. Beta blockers, used for blood pressure and heart rate management, and many antihypertensives more broadly. The combined anticholinergic load can be substantial, producing dry mouth, constipation, urinary retention, cognitive impairment, and confusion collectively from the combination of drugs. In some cases, switching from one medication to another within the same therapeutic class or adjusting timing of existing medications meaningfully reduces dry mouth without changing the therapeutic target. Sjogren's syndrome is an autoimmune condition in which the immune system attacks the moisture-producing glands of the body, primarily the salivary glands and the lacrimal glands of the eyes. The distinction between Sjogren's related morning dry mouth and other causes lies in the combination and chronicity of symptoms. Sjogren's dry mouth is persistent. Diagnosis involves specific blood tests, anti-SSA and anti-SSB antibodies, rheumatoid factor, and ANA, along with salivary gland function testing. Dehydration is the obvious one. Most adults over 60 are chronically mildly underhydrated due to the blunted thirst mechanism I have described in previous videos. The simple intervention of deliberate evening hydration, 1 glass of water consumed an hour before bed, chosen specifically to address overnight fluid loss without creating excessive nocturia disruption, reduces morning dry mouth attributable to dehydration in a proportion of people who try it. If morning dry mouth resolves completely with this intervention, the diagnostic picture is relatively straightforward. Before finishing, a practical summary of what to do with this information. If morning dry mouth is new, it warrants a physician visit. If morning dry mouth is accompanied by any of the warning signs I described, those accompanying symptoms should be listed and presented together because the combination tells a more specific diagnostic story. And if you are in the category of adults who have been experiencing this symptom and simply not mentioning it, I want you to reconsider that assessment. Morning dry mouth in the right context is one of those signals, and now you know what context to look for.